Your Excellencies, honorable ministers, distinguished colleagues, partners, and friends. I'm Dr. Teresa Kasayeva, Director of the WHO Global Tuberculosis Program at the World Health Organization. It's truly a pleasure to be welcoming you to this side event entitled Ending TB Death Among People with HIV, Step Up the Momentum, which we are holding on the eve on the United Nations high-level meeting on HIV/AIDS. This side event aims to provide a platform for member states to reassert their commitment to ending TB death among people living with HIV and to deliberate how they will intensify their response to HIV-associated TB within the context of COVID-19. It's important to note that TB remains among the top infectious killers in the world and is the leading killer of people with HIV. We are holding this event today to highlight the need to maintain and increase the profile and focus on HIV-associated TB at the UN high-level meeting, as well as to reaffirm high-level commitment from participating UN member states and TB and HIV/AIDS stakeholders to fast-track action to end TB death among people with HIV. This event also aims to share and discuss urgent actions to intensify scale-up of TB diagnosis, treatment, and prevention interventions in the context of devastating COVID-19 pandemic. We are very pleased to welcome our distinguished lineup of high-level speakers, including the WHO Goodwill Ambassador for Tuberculosis and HIV/AIDS, the First Lady of China, Her Excellency Professor Pen Luan, the UN high-level meeting co-facilitators from Namibia, Honorable Minister of Health and Social Services for Namibia, Dr. Kalumbi Shangula, and from Australia, Dr. Stephanie Williams, the Australian Ambassador for Regional Health Security, Department of Foreign Affairs and Trade, and Honorable Ministers of Health, WHO Deputy Director General Dr. Zsuzsanna Jakab and Dr. Shannon Haider, Deputy Executive Director of UNAIDS, who will deliver their opening remarks. After the opening statements, we will then move to the ministerial session and where we will hear a perspective from some of the countries with a high burden of HIV-associated TB. Honorable Minister of Health of Indonesia, Dr. Budi Gunadi Sadikin, and the Honorable Minister of Health for Nigeria, Dr. Osagi Ehanire. They will update us on progress made on HIV-associated TB and plans for advancing the response to accelerate progress towards national and global targets, and importantly, to reduce human suffering. We will then move to an interactive panel where we will hear from Merinda Sibayang, a TB/HIV patient advocate, as well as heads of agencies and high-level representative from key partners on the essential actions that need to be urgently prioritized to end TB death among people with HIV. We will also hear about what key messages that we would like to see coming out of the UN high-level meeting on HIV/AIDS. Before I set the scene for this event, I would like also to thank our audience who is growing, who have joined us today. This event is becoming live streamed on YouTube and will be posted on the WHO website. We welcome your questions for the interactive stakeholder panel with our key partners. This will be curated for use at the question and answers session if the time will permit. If we will look back at the last two UN high-level meetings on TB and HIV, there has been considerable progress towards reaching the targets related to HIV-associated TB. Ministries of Health, in collaboration with the partners and communities, have really forged ahead to scale up TB HIV collaborative activities, including expanding access to antiretroviral therapy and TB preventive treatment. These have been life-saving interventions. By 2019, AIDS deaths attributed to TB had dropped by 63% compared with 2010. This is in the context of the 2020 targets of a 75% reduction. 5.3 million people living with HIV were started on TB preventive treatment in 2018 and 2019, which was 88% of the way towards the 5-year target of 6 million. This sub-target for TB preventive treatments set in the political declaration of the UN high-level meeting on TB is well on track to be achieved by 2022. But of course, we all understand these devastating impacts and effects of the COVID pandemic, but it's not the reason to give up. It's the reason to double and triple our efforts. Almost 90% of registered TB patients living with HIV received antiretroviral treatment in 2019. Of course, despite these achievements, we all know what was the impact. And since the very beginning of the COVID-19 pandemic, we are monitoring situation almost on real-time base, and based on our monthly data reported by more than 91 countries, at least 1.4 fewer people received access to essential TB services. And it's very concerning. It's 21% reduction in compare with the previous year. And in the highest TB burden country, it's even more, up to 40%. It's extremely concerning. This lack of access also means that transmission is continuing, and communicable diseases in general is a big issue. We are now focused on COVID-19, but we should not neglect other so-called old and ongoing epidemics of 3 diseases: TB, HIV, and malaria. This UN high-level meeting on HIV/AIDS provides an opportunity to reflect on how far we have come, deliberate on lessons learned, and urgently step up action to ensure no person with TB or HIV loses their lives or faces suffering due to these dual epidemics. This is critical now more than ever as we grapple with the COVID-19 pandemic. So, without further delay, I would like to welcome the distinguished delegates in the opening panel to take the floor. It's my pleasure to ask the UN high-level meeting co-facilitator representative and Honorable Minister of Health and Social Services for Namibia, Dr. Kalumbi Shangula, to kindly take the floor and open the meeting. Please, Dr. Shangula, floor is yours. We have a lot of opportunities due to the teleconnection, but also sometimes from time to time we're facing challenges. Honorable Minister has just been connected, but seems that there are some issues. We're trying to solve them. Hope he will come soon. So, dear colleagues, in the interest of time, we hope that Minister will connect with us very soon. We are moving and welcome another co-facilitator representative, Dr. Stephanie Williams, Australian Ambassador for Regional Health Security, Australian Department of Foreign Affairs and Trade. Thank you, Dr. Williams, and please, floor is yours.
Thank you, to WHO for hosting the discussion today on an important issue, as we all know, at a very important time. I'm Dr. Stephanie Williams, Australia's Ambassador for Regional Health Security, and in opening remarks, my job is to share some reflections and set the scene for the discussion. Tomorrow being the first day of the 2021 high-level meeting of the UN General Assembly on HIV/AIDS, and Australia is proud to be working with Namibia to co-facilitate the political declaration to be adopted this week. As co-facilitator, Australia has sought to progress an ambitious declaration that puts human rights, science, and addressing inequalities at the centre, a declaration to guide the global response back on track. We all know, however, that the work does not end with the adoption of a political declaration. COVID-19 has exposed the frailty of public health systems in so many countries, and we've seen those at risk of HIV experiencing greater difficulty in accessing treatment, testing, and prevention. We know the same could be said for TB patients. Our focus on fast-spreading new diseases such as COVID-19 has reduced attention to the other key diseases. We cannot afford for that to continue to happen, but more so, the lessons from the HIV response, from the TB response, are critical for the COVID control. The high-level meeting on HIV/AIDS is also an important opportunity to keep the focus on universal health coverage, integrated approaches to managing HIV and TB. Australia has been pleased to achieve and maintain good TB control since the mid-1980s, around the same time we saw the emergence of HIV. Our successful response to HIV and TB has always been and continues to be grounded in partnership and collaboration between government, community groups, key populations, researchers, clinicians, civil society organisations. Today, AIDS is considered virtually eliminated in Australia, and the rates of new HIV and TB infections are among the lowest in the world. While we have had success at home, we know TB in particular remains a significant threat in our region and globally. And in recognition of this, we continue to support countries, prioritise strong, resilient health systems, and in turn, that promotes regional health security. Practically, that means we assist countries in the region to access Global Fund grant money for TB control, as well as providing ongoing bilateral TB control program support. Throughout COVID-19, we have continued our focus on TB in our near region. While we must celebrate the wins to date in the HIV response, at the same time, we need to make the most of the opportunity we have this week at the high-level meeting to commit to renewed action on HIV, commit to continuing to strengthen health systems, apply evidence, and involve communities in a more ambitious response. I'm really looking forward to the perspectives to be shared by panelists today. Thanks for the time.
Thank you very much, Dr. Stephanie Williams. Thank you for your statement. Thank you for your outstanding work as a co-facilitator. And now again, with pleasure, I would like to turn to the Honourable Minister of Health and Social Services for Namibia, Dr. Kalumbi Shangula. Please, Your Excellency, floor is yours.
Thank you very much, moderator. Your Excellencies, Namibia appreciate the privilege to be the co-facilitator of this forum. We are living in unprecedented times, the times of COVID-19. But we know that we are living with existing conditions prior to COVID-19, and we need to put our attention to our mandate, which has been given to us to serve humanity in the field of health. I join my co-facilitator, the distinguished member from Australia, with whom Namibia has the pleasure to working together and to advance the agenda of humanity. The high-level meeting is preceded by a very important milestone in the fight against HIV/AIDS. This year, the new strategy was adopted, and I think it's critically important that this gives us a momentum on which to build our future action. And it's very important that we maintain this momentum. In order for us to move ahead with great speed and urgency, I would like to lift out some of the few efforts which needs to be done for us to achieve our objective. We need to end the intersecting inequality which are existing and which are obstructing our progress towards ending AIDS. We need to prioritize HIV prevention. And I always like to quote the old axiom that prevention is always better than cure. We need to close the gap in HIV testing, treatment, and viral suppression, and move with speed to achieve the 95, 95, 95 targets. Critically important to eliminate vertical HIV transmission and eliminate pediatric AIDS. And above all, we need to create the necessary environment for action and to enhance global solidarity in order to close the gaps which are existing in our HIV responses, both in terms of human and financial resources. What is also critically important is for us to be able to monitor the progress so that we can plan, replan, readjust as the circumstances dictates. I would like to look forward to the discussions this afternoon. The discussion, I believe, will serve as building blocks for us to move ahead together. I thank you.
Thank you very much, Your Excellency. Indeed, we applaud for your leadership to advance agenda of humanity, as you absolutely rightly highlighted. It's so important, even acknowledging that we are in the midst of COVID-19 pandemic, but other diseases and millions of people suffering should not be neglected. It's now my pleasure to give floor to WHO Deputy Director General, Dr. Zsuzsanna Jakab, to take the stand.
Your Excellencies, Honorable Ministers, distinguished delegates, ladies and gentlemen. As we come together at this high-level meeting to recommit to the global fight to end AIDS, I would like to share the significant progress that has been made and the challenges that remain to reach the 75% target of reducing death from HIV-related tuberculosis by 2020 compared with 2010 agreed to by the heads of state in 2016. In 2018, at the UN high-level meeting on TB, member states also committed to addressing HIV-associated TB, including providing TB preventive treatment to 6 million people living with HIV by 2022. Based on the latest data reported for 2019, we have seen a notable reduction of 63% in HIV-related deaths globally, and 5.3 million people living with HIV had been on TB preventing treatment, which is a great achievement. Despite impressive scale-up of antiretrovirals and collaborative TB-HIV activities, tuberculosis remains the leading killer of people with HIV. In fact, in 2019, 30% of AIDS-related deaths were due to tuberculosis. The COVID-19 pandemic has had a devastating impact on the delivery of services for tuberculosis and HIV, and reversed progress in achieving global targets and ending death from tuberculosis. But COVID-19 has also catalyzed out-of-the-box thinking for delivering healthcare. It has fast-tracked research and development, and it has underscored the importance of collaboration with other sectors and communities. During the discussion today, and at the United Nations high-level meeting, we must remember that it will be impossible to end death in people with HIV without bold action and bold commitment to address tuberculosis. We need to build on commitments across both diseases made at high-level meetings and as urged by the United Nations Secretary General in his TB Progress Report, as well as learn lessons from our fight against the pandemic. As highlighted by the WHO Director General in his opening remarks at the 2021 World Health Assembly, we must address the vulnerabilities that allow outbreaks to become epidemics and epidemics to become pandemics. Therefore, we should build on the progress made so far to end these epidemics for good. WHO stands committed to support this fight for health for all. Working together in solidarity, we can get back on track to ending the AIDS epidemic and build a healthier, safer world for all of us. Thank you.
We thank DDG Dr. Zsuzsanna Jakab for her inspiring speech. And it's now honor and my great pleasure to introduce WHO Goodwill Ambassador for Tuberculosis and HIV/AIDS, the First Lady of China, Her Excellency Professor Peng Luan.
女士们、先生们、朋友们，大家好。在今年联合国大会艾滋病问题高级别会议召开前夕，世界卫生组织举办结束艾滋病人因结核病死亡提升势头视频会议，很有意义。艾滋病和结核病是严重危害人类健康的重大传染病。近年来，在世界卫生组织、联合国艾滋病规划署的推动下，在国际社会共同努力下，全球艾滋病和结核病防治工作卓有成效。 中国自2004年启动艾滋病和结核病双重感染防治工作以来，取得了显著的进展，已逐步建立起艾滋病和结核病防治机构合作机制。多年来，艾滋病持续控制在低流行水平。近20年来，结核病发病率下降40%以上，死亡率下降70%以上。这些成果的取得，得益于中国政府的高度重视、医护人员的不懈努力和广大志愿者的默默付出。大爱无疆，大道无垠，一路走来，我见证了许多感人故事。李小丹，在他读高中的时候就参与到艾滋病防治活动中，在读大学期间，每年都到农村看望受艾滋病影响的儿童，陪伴关爱他们。他将艾滋病红丝带的志愿服务融入到他的生命，并成为他毕生的追求。他的行动诠释了志愿者与受艾滋病影响的儿童永远在一起的信念，更成为了彼此生命中的亲人。另一位是徐兴华，来自于中国云南。他曾经是结核病患者，因为病痛的折磨，他曾多次想到过放弃治疗。经过积极而规范的治疗后，他最终勇敢地战胜了病魔。痊愈后，他成为了一名志愿者。他关心关爱其他患者，把防治结核病的知识结合自己的治愈经历分享给他们，使他们树立了信心，度过了难关。在新冠肺炎疫情期间，他和像他一样的志愿者们协助医务疾控人员，没有让一名结核病患者中断治疗。在这里，我向世界各地像他们一样为防治艾滋病、结核病默默奉献的人士和志愿者们表示诚挚的敬意。女士们、先生们、朋友们，重大传染性疾病是人类面临的共同挑战，消除艾滋病和结核病威胁是我们的共同心愿。当前，新冠肺炎疫情仍在全球蔓延，给防治艾滋病和结核病带来更多的挑战，需要我们共同努力，为爱守护，奋力前行。在此，我呼吁各国各界人士携起手来，积极行动，加强艾滋病和结核病防治工作，让更多防治成果惠及人类健康，为构建人类卫生健康共同体做出努力。谢谢大家。
And we thank Her Excellency, the First Lady of China, for her outstanding leadership, passionate leadership, and for continuing engagement and support to those most vulnerable. And finally, I would like to welcome another outstanding leader and passionate advocate, Dr. Shannon Haider, Deputy Executive Director of UNAIDS, to make opening remarks on behalf of UNAIDS. Please, Shannon, floor is yours.
Oh, thank you so much. Thank you to WHO and the conveners, and thank you to our dedicated co-facilitators who have been showing leadership throughout the organization of this high-level meeting. Your Excellencies, honorable ministers, colleagues, friends, you know, Saturday we recognized 40 years since the initial reporting of HIV. Yet it's been nearly 140 years that we've identified the bacteria that causes TB, and we've had centuries of disease. We've had nearly 70 years of cures for TB. So where are we in the place we're at now? What's the cautionary tale of public health failure of cure? We think it's a couple of things. One is complacency and two is inequalities. You know, once there was a cure and TB cases fell, especially in wealthy countries in the 60s and 70s, complacency set in. TB got integrated into general clinics, the push for new drug development fell off, and it took an unexpected resurgence of complicated TB associated with the HIV epidemic and a surge in MDR TB to slowly regalvanize the investments and the innovation that we have now. And in other ways, the non-medical aspects of TB, the inequalities, have never been fully attended to. The stigma and discrimination, including employment discrimination, the role of poverty, malnutrition, and built environment in the risk of disease, and the catastrophic costs to affected families. So when it comes to these colliding epidemics of TB and AIDS, there's more than just the intersections of microbiology and disease. There are intersecting inequalities. And to be successful in responding to the colliding epidemics, we must intensively target disparities in access and outcomes, and also address the socioeconomic contexts that get in the way. As you've heard from our speakers already, we're not there yet. TB remains the single largest cause of death for people living with HIV, with over 200,000 lives lost in 2019 alone from TB among people living with HIV. And that's because half of the people with HIV, TB each year are still being missed from diagnosis alone. But as you've also heard, we've made progress, and some countries are doing even better than others. By 2019, there were already 9 countries who had either met or exceeded the 75% reduction in TB deaths since 2010. We need to learn from those countries. And as you've also heard, we've also finally started to do more to prevent TB among people living with HIV. As you've heard, in just 2 years of implementation since the TB high-level meeting, we've reached nearly 90% of the target of reaching people living with HIV by TB preventive therapy. Of course, that might mean that we set the targets too low, that we needed to be more ambitious. But we really do need to acknowledge that not everyone is benefiting from that TPT rollout. And we are especially missing children who are household contacts of active TB family members. And as you've heard, COVID-19 hasn't helped. Early studies suggest people living with HIV and people with TB who are infected with COVID-19 are twice as likely to die. And the disruptive impact of COVID goes far beyond this, with resources diverted and access disrupted. In Kenya, Malawi, and Zimbabwe, COVID-19 brought an over 50% decrease in screening for presumptive TB, with an 80% decrease for children. Children, again, being left further behind. So to end the AIDS and TB colliding epidemics, we must shift focus on where, why, and for whom the response and the interventions are not working. But we know the shift is possible. We've seen countries adopting innovative health interventions with communities' active engagement. In Malawi, the Lighthouse Clinic scaled up multi-month prescription and dispensing of HIV and TB medications, and they implemented the screening and testing for HIV, TB, and COVID-19 at the same time. In South Africa, community-led monitoring through the Stop Stockout project has identified site stockouts of both HIV and TB drugs in real time, so that urgent measures could be taken to fill in those gaps. And strong partnerships, such as those which WHO and UNAIDS have built over the years with Her Excellency Goodwill Ambassador, Madam Peng Liang, have helped empower affected communities as well. Our collective new global AIDS strategy calls for resilient, people-centered, rights-based, and integrated services for HIV and TB. And it also calls for us to address the societal context that provides greater inequalities and risks. With the new 2025 TB HIV targets, we will reduce TB deaths among people living with HIV by 80%. To do that, we need community-led organizations to be directly financed and fully equipped. And we must not lose momentum during the COVID pandemic or its recovery, but instead we must team up, shout loudly now more than ever before for aggressive investments in these colliding epidemics to save lives, support families, decrease the intersecting inequalities of TB and HIV. Thank you.
So thank you very much, Shannon, for your great work and collaboration, for real partnership. And you're absolutely right. And as our Director General, Dr. Tedros said, we don't have a vaccine from inequality, but we all can make difference collaborating actively together. So I would like now to hand over to my colleague, Dr. Meg Doherty, the Director of the WHO Global HIV, Hepatitis and Sexually Transmitted Infections Program, to moderate our ministerial panel. Meg.
Thank you very much, Dr. Kaseva, and I would like to also thank and be all of the organizers for this important session, and so glad that we are here collaboratively still tackling the issues of TB and HIV, as these are needed more so as we go forward. So the next 15 minutes we'll hear from our colleagues and ministers from high-burden TB, HIV countries. And we're going to learn about the excellent advances they've made from their respective programs. These countries are focusing on the diagnosis, treatment, and prevention of TB among people living with HIV. And now that we have new numbers that tell us that we have at least started to decrease our new HIV infections down from 1.7 million in 2019 to 1.5 million in 2020, we need to take that energy and put it towards reduction of deaths, because we've seen a stalling in the reduction of HIV AIDS-related deaths, and we know many of those are related to and due to tuberculosis. So we need to do more, and I believe the honorable ministers will be providing us examples of how they're working to end TB deaths and to address all of the NTB goals for 2030. So it is my pleasure right now to then introduce Honorable Minister Budi Gunadi Sadiq, Minister of Health of Indonesia, and who will be sharing some of the innovations about how he and his program are planning together to reduce TB deaths. Over to you, Honorable Minister.
Excellencies, ladies and gentlemen, tuberculosis is an ancient disease that one can only imagine it should no longer exist in the present world. Yet today, tuberculosis still infects about a quarter of the world population. Tuberculosis also remains the leading cause of death from a single infectious disease, both in the general populations and especially among people living with HIV. Indonesia, like in many countries, continues to accelerate a comprehensive response to end tuberculosis death among people living with HIV. We commit to providing access to quality and affordable prevention, diagnostic, and treatment measures. Since 2018, Indonesia has included tuberculosis and HIV services as a part of the minimum standard services that all districts and municipalities in Indonesia must provide. To date, more than 90% of 514 districts or municipalities in Indonesia have developed and implemented sound tuberculosis HIV programs, including routinely conducting tuberculosis HIV cases notifications. Since the last high-level meeting on tuberculosis in 2018, the number of tuberculosis patients tested for HIV has increased significantly. That resulted in an increased number of people with known HIV status. This has enabled us to improve treatment coverage accordingly. We estimated that in 2019, there are 19,000 new tuberculosis patients with HIV infections and 4,700 tuberculosis deaths among people living with HIV. To address the intersectionality between tuberculosis and HIV, Indonesia has aligned the National Tuberculosis Prevention and Control Program with the national HIV prevention and control. First, by aligning policies and guidelines for tuberculosis, HIV, and maternal and child health services. Second, by ensuring that effort to expand and accelerate collaborations of tuberculosis, HIV, and maternal and child health services are supported by adequate and capable human resources. Third, by improving tuberculosis and HIV data management and integrating health information systems. Fourth, by ensuring the availability of logistics for detection, management, and prevention of tuberculosis HIV cases, including for pregnant women. Fifth, by engaging local community in DOTS program to monitor and provide assistance to tuberculosis patients in order to increase their adherence to finished medications. Sixth, by strengthening and expanding the tuberculosis preventive treatment among all people living with HIV. Excellencies, ladies and gentlemen, COVID-19 has been disruptive to our global health system. In mid-2020, we have identified tuberculosis and HIV-related services as one of the disrupted essential health services during the pandemic. There are 54% decrease in tuberculosis case notification and 10% in new HIV-infected case finding. Through this pandemic, Indonesia remains committed to the continuity of tuberculosis and HIV services as part of the essential health services. This is vital to prevent unnecessary tuberculosis death among people living with HIV. We implemented community-based tuberculosis HIV treatment using video-observed therapy and teleconsultation. We also provide home care services to tuberculosis HIV patients without complications. And we transfer tuberculosis HIV services to non-COVID-19 health facilities to limit COVID-19 exposure to the already vulnerable population. Excellencies, ladies and gentlemen, tuberculosis deaths among people living with HIV are senseless deaths that can be prevented. To do that, we must step up the momentum that we have built over the years, now interrupted by this pandemic. By working together, building on our strength, and putting resources where our mouth is, I strongly believe that we can achieve our shared vision of preventing tuberculosis death among people living with HIV by 2030. Thank you.
Thank you, Your Honorable Minister. Excellent examples of how you have been stepping up the effort to reduce tuberculosis deaths among people living with HIV, and certainly coming up with innovative approaches such as community-based care and video service care during the time of COVID. So thank you very much. Excellent examples that can be taken to other countries as they step up their efforts as well. It is now my great pleasure to introduce the Honorable Osagi Ihari, Minister of Health of Nigeria, who also will be presenting on their approaches to end tuberculosis deaths among people living with HIV. Over to you, Honorable Minister. Thank you.
I am honored to speak on this important topic titled Ending Tuberculosis Deaths Among People Living with HIV, Step Up the Momentum, at the side event of the United Nations High-Level Meeting on HIV and AIDS. This event will no doubt afford Nigeria the opportunity to present some of the life-saving interventions for TB HIV co-infected patients while at the same time learning best practices on collaborative TB/HIV activities. Nigeria is on the WHO list of 14 countries with the triple burden of TB, HIV-associated TB, and multi-drug resistant TB. Based on the 2020 WHO Global TB Report, 46,000 people living with HIV in Nigeria fell ill with TB in 2019. Similarly, out of the estimated 155,000 TB deaths during the same period, 27,000 were among people living with HIV. Our national strategic frameworks for TB/HIV collaborative activities, as well as national strategic plans for TB and HIV, are focused on tackling the burden of TB/HIV with evidence-based interventions that improve the quality of life, as well as reduce TB deaths among co-infected persons in Nigeria. Some of these interventions include updated guidelines for management of TB/HIV co-infection that were distributed to health facilities to support clinical management of co-infected patients. The training and retraining of healthcare workers on management of TB/HIV co-infection. The introduction of one-stop shop facilities for integrated management of TB/HIV co-infection, with more than 90% of 1,435 antiretroviral therapy sites being offered TB services in 2019. The strategic and operational focus on reducing the impact of TB on HIV and conversely, reducing the impact of HIV on TB by active TB case finding among people living with HIV through provider-initiated screening of people living with HIV at any encounter within the health system, to link people living with HIV with presumptive TB to rapid molecular TB diagnostics with expert MTB-RIF assay and chest X-ray. This has been done since 2011. Diagnosed TB patients are promptly commenced on treatment with high-quality TB medicine. People living with HIV with latent TB infection receive TB preventive therapy, of which coverage has risen from 15% in 2014 to 73% in 2019. TB screening with urine, lateral flow, lipo-arabino, Manan, and expert MTB-RIF assays was recently added to the package of care for people living with HIV with advanced disease. To reduce the impact of HIV on TB, we ensure improved access to highly active antiretroviral therapy with the recent introduction of dolutegravir containing regimen for HIV-infected persons. The integration of HIV test and treat policy in 2016 to overcome barriers to early treatment of newly diagnosed HIV patients, and so to reduce mortality from opportunistic infections, including TB. Diagnosed TB cases are tested for HIV with an average consistently over 94% in the last 6 years. Regular performance review meetings on collaborative TB/HIV activities with action plans that are implemented to improve quality of care to co-infected patients. With this range of interventions, we have sustained a decline in HIV-positive TB mortality rate from 49 per 100,000 in the population in 2013 to 14 per 100,000 in the population in 2019. We look forward to learning best practices on collaborative TB/HIV interventions in order to further improve quality of care given to co-infected patients and ultimately to end deaths from co-infection. I thank you all for this opportunity and also for your listening attention.
Thank you, Honorable Minister. And it's very, very heartening to hear that Nigeria is implementing many of the WHO recommendations and guidelines, and with that, finding success in addressing the co-infection of HIV and TB through integrated management and reduction of advanced HIV disease. Certainly that will help us reach the ending of TB deaths and our goals for the SDGs and for the next high-level meeting for tuberculosis. So with that, I would like to pass back to my colleague, Dr. Teresa Kaseva, who will continue with the next part of this session. Thank you very much.
Thank you very much, Meg. It was extremely important and interesting panel. Honorable ministers shared their experience, and it shows that even during COVID pandemic, it's possible to move on with and address essential needs of people with TB and HIV. Now it's time for our interactive stakeholder panel. We have 6 great speakers and representative of our key stakeholders, and they are Miss Mirinda Sebayang, who is chairperson of the Ringan Indonesia Positive, the Indonesian network of people living with HIV. Ms. Kerry Pelsman, acting assistant administrator in the Bureau for Global Health, USAID. Mr. Peter Sands, executive director of the Global Fund to fight AIDS, TB, and malaria. Dr. Anjali Aklikar, acting US Global AIDS coordinator and special representative for global health diplomacy, and the United States President's Emergency Plan for AIDS Relief. Dr. Lucic, Adity, executive director of the Stop TB Partnership, and Dr. Hank Tomlinson, director of the Division of Global HIV and TB at the US Centers for Disease Control and Prevention. As I told, this will be interactive session where we'll hear from our distinguished panelists on what priority actions and messages they would like to hear emerging from the UN high-level meeting this week. We welcome questions from our audience. We see it's growing, more than 200 participants already. Questions to the panelists, please use the Q&A function. Time permitting, we will try to respond to a few questions live. And I will immediately turn to our first panelist, Mirinda Sebayang, as a TB and HIV advocate and someone who has experienced HIV-associated TB. What do you think are the key elements, ingredients for ending death and suffering from TB among people living with HIV? Please, floor is yours.
Thank you so much, Dr. Teresa. So this is my great pleasure today to be present at this historic opportunity in the side event of UN high-level meeting on ending TB deaths among people living with HIV. So I also want to express my gratitude and also appreciation to the HIV and TB program in my country, Indonesia. It's currently back on track, especially for TB, now become a priority program from the President of Indonesia. So let's start with number first. So in the Global AIDS Strategy 2021 up to 2026, it is mentioned that targeted related to TB HIV, including 90% of people living with HIV received preventive treatment for TB. 90% of patients entering care through HIV or TB services are referred for TB and HIV testing and treatment at one integrated, co-located, or linked facility depending on the national protocol. And the target also mentioned that reduced by 80% TB deaths among people living with HIV, and also 90% people in humanitarian settings have access to integrated TB, hepatitis C, and also HIV services, in addition to programs to address gender-based violence, including intimate partner violence, which include also HIV post-exposure prophylaxis, emergency contraception, and also psychological first aid. So epidemic modeling also shows that achieving the comprehensive 2025 targets, it will reduce annual HIV infection from an estimated 1.7 million in 2019 to less than 370,000 in 2025. And also it will reduce annual adult and children AIDS-related deaths, including TB deaths among people living with HIV from around 690,000 in 2019 to less than 250,000 in 2025. So we can see that this degree of success in the HIV response will put the international community firmly on track to end the AIDS epidemic in all settings for all populations by 2030. No one can deny that TB is still accounting for roughly 1 in 3 deaths among people living with HIV. So we call for urgent attention to the unfinished agenda of addressing the twin epidemic of HIV and TB. And also, although TB is preventable and treatable, this is still the leading cause of death. Everybody said that. So less than half of the estimated incident TB cases among people living with HIV are diagnosed and treated appropriately, and there is still poor uptake of treatment regimens, especially for latent TB infection. So we must intensify the efforts towards comprehensive and integrated health services. This is also include linkages between HIV services and support services for other communicable and also non-communicable diseases. And we also have to speak about other services such as mental health, alcohol, drug use, and substance dependence, and also services for sexual and reproductive health, gender-based violence, and also including harm reduction. And we must also expand right-based community contact tracing and scale up access to the latest technologies for TB screening, diagnosis, treatment, and prevention for people living with HIV. And of course, we have to ensure optimal linkages to HIV care. Existing health services often fail to address the HIV-related and other needs of people who need them most. This is due to discriminative attitudes or lack of sensitivity to the needs of key populations and priority populations. And dedicated HIV services do not always meet the broader health needs of people living with HIV or affected by HIV. So people-centered system for health must ensure that health and community system and social structural enablers optimize the impact and sustainability of HIV programs. So if we speak about integrated service package, we have to ensure that they are tailored and delivered in ways that place people at the center, put people at the center. They can help rapidly reduce inequalities in the HIV response, as well as support the universal health coverage. Last but not least, so from my perspective, the TB response also can learn from HIV response, vice versa, that recognize the role of communities and people affected by TB. There needs to be room for robust collaboration among people living with HIV and also the community of former TB patients. As stated in the political declarations of the UN General Assembly high-level meeting on TB in 2018, increased commitments is needed to develop TB community-based health services through approaches that protect and promote equity, ethics, gender equality, and human rights in addressing tuberculosis by focusing on prevention, diagnosis, treatment, and care. This is also including socioeconomic, psychosocial support that reduce stigma and integrated care for related health conditions, such as HIV and AIDS. Over to you, Dr. Teresia, thank you.
Thank you very much, Mirinda. Can't agree more with all your points. Absolutely relevant and key. And of course, we can see how high-level commitments and actions can make difference in our actions and in our progress. And this is, of course, very challenging time. But it's in the same time, it's time to learn from the experience of the COVID-19, TB, HIV, and definitely we can make, and we should do the difference for people the most vulnerable and the poorest. So with this, I would like to thank you once again and to turn to my our next panelist, is Carrie Pelsman. As the top bilateral donor for TB, how is USAID considering prioritizing efforts to end TB among people with HIV? Please, Carrie, would like to hear from you.
Thank you. Good morning, good afternoon, and good evening. It is an honor to join you all today alongside so many of our key and esteemed partners as we work together to end HIV and TB globally. So many of the earlier remarks conveyed essential messages. It was particularly powerful, I thought, to hear from the ministers and other country leaders, as well as, of course, the crucial voice of advocates. Although currently serving as acting assistant administrator in USAID's Bureau for Global Health, in my role as a foreign service officer, I've served in countries with high burdens of both TB and HIV. I've seen firsthand the importance of the work we do to end both epidemics. As the top bilateral donor for TB, USAID leads the US government's global TB efforts and is a key implementer of PEPFAR programs to address the specific challenges presented by TB HIV. Our focus is implementing collaborative TB HIV activities to drive progress on 4 fronts. 1, assisting with establishing and strengthening the mechanisms for coordination of TB and HIV activities and services. 2, decreasing the burden of TB in people living with HIV. 3, decreasing the burden of HIV in individuals with active TB. And 4, initiating early antiretroviral treatment for people living with HIV with active TB disease to increase survival and improve quality of life. USAID's global TB program focuses on reducing the HIV burden among TB patients, and our efforts ensure that individuals with TB know their HIV status through HIV testing during TB clinic visits. TB patients who test positive for HIV are linked to care providers or networks to receive antiretroviral therapy as appropriate. In the last decade, we've made tremendous progress in this area, and our significant achievements reflect national TB programs' strong commitment to address HIV, as well as the dedication and commitment of frontline healthcare workers, including community health workers and advocates such as we've just heard from. For example, last year, PEPFAR USAID programs and our country partners ensured that 95% of the individuals with TB were also tested for HIV and linked 94% of individuals with TB and HIV to antiretroviral therapy regimens. These efforts have greatly contributed to reducing the burden of HIV among TB patients. USAID also works with partners and local governments in PEPFAR-funded countries to scale up effective TB-HIV interventions aimed at reducing the burden of TB for people living with HIV. We provide support to HIV programs to intensify TB case finding and TB preventive treatment among people living with HIV. Under PEPFAR, as I'm sure Dr. Achrekar will underscore, significant progress has also been made in scaling up TB preventive treatment. However, there is still work to do in identifying all active TB cases among people living with HIV and placing them on anti-TB therapy, as only about 56% of PLHIV TB cases are currently diagnosed. USAID remains committed to driving progress on this important objective. USAID also remains committed to the recovery from COVID-19's impact on TB programs. As a second-order impact of the pandemic, the global TB response has been severely impacted, reversing up to 12 years of progress. We've already seen an alarming drop in reported TB cases. In the 23 countries where USAID focuses TB programming, 1 million fewer people with TB had access to diagnosis and treatment in 2020 compared to 2019, representing a 23% decline. As the worst case scenarios in modeling studies have predicted, this decline inevitably will result in more suffering and deaths from tuberculosis. To address the pandemic's devastating impact on TB, through USAID's Global Accelerator to End TB, the agency has just released urgent TB recovery plans in 7 high-burden TB countries. Designed in collaboration with partner governments and the Global Fund's TB catch-up plans, these efforts will provide a foundation for these countries to recover lost ground in the global effort to end TB. Key to recovery from these reduced TB case notifications is to remain focused on finding TB cases, including among those people living with HIV. USAID is committed to this effort both through our work with PEPFAR and as we lead the global TB response. However, clearly we cannot and will not do it alone. Renewed attention and resources are required to recover from COVID-19 setbacks, accelerate our efforts to help countries get back on track to reaching the United Nations high-level meeting on TB targets by 2022, and ultimately end both epidemics. President Biden has underscored the role of US leadership toward ending the COVID-19 pandemic and strengthening global health security. Our joint efforts will continue to build a world that is safer and more secure against the threat of infectious disease. I hope today's session helps to inspire us all toward these goals. Thank you.
Thank you very much, Carrie, for your really very inspiring and strong commitments, leadership, and continuing support. It's vital and essential to keep world on track and to provide further progress towards our targets to end epidemics and the TB and HIV epidemics. So thank you very much. With this, I would like to turn to our next speaker, and you see our panel is very well gender balanced. It's Peter Sands, Executive Director of the Global Fund to Fight AIDS, TB, and Malaria. And my questions, of course, will be related to the funding, financing, and nothing could be done. And the current moment shows that we need more investments in the TB HIV response, and in the same time we can see that it's possible looking how fast and effectively funds are raised for the COVID response. So what lessons could you share from the Global Fund experience and perspective in COVID-19 funding, lessons learned, what could be applied to the TB, HIV programs, and how we can do things better, more effectively?
Teresa, thank you for that and for giving me the opportunity to speak today. And I'd also like to say how much I enjoyed and agreed with both Mirinda and Carrie's contributions just now. You asked me about funding, and underneath funding always is political will and commitment. If the political will and commitment exists, you tend to get the funding. And if it doesn't, you don't. And when you think about TB and HIV together, actually, we know a lot about what to do. And both Carrie and Mirinda were talking about some of it earlier, and some of the earlier speakers, some of the ministers I was listening to. And although we could always have better tools, the reality is we do have tools that can make a huge difference. We have treatments for TB, we have preventative prophylactics, we have diagnostics that work. The biggest challenge we face around TB and HIV together is the fact that the politics and the political commitment to tackle it isn't of a scale that is commensurate with the challenge, with the number of lives being lost, with the degree of suffering that the combined diseases present. And that is something that I think we need to, in a sense, reflect on and act on in the context of COVID-19. TB and HIV were and are pandemics themselves. They're just ones that have somewhat slipped off the radar screen. And the reality is they've slipped off the radar screen because now the people they are killing are not those who are living in the richest countries in the world, are not those among the elites, but among the poorest, most vulnerable, most marginalized populations in the world. And I think we need to draw a lesson for that for the COVID response, which is that we cannot let that happen with COVID, that it ends up being yet another, in a sense, residual pandemic that we then describe as being endemic, that we don't get rid of. But also we should take it as an impetus to challenge where we are on HIV and TB, that we should say, if we can get rid of COVID in the world, we should absolutely be able to get rid of HIV and TB. The way TB and HIV combine also to cause suffering and kill people is a reminder that pathogens don't exist on their own. A lot of the dialogue and debates around COVID seem to be as if COVID was entirely on its own, right? As if there's one disease and the only metric of success was how many people you could save who might otherwise die of COVID. TB and HIV demonstrate that actually pathogens interact and build on each other. And as we all know, TB is the leading cause of death of those people with HIV. And the same is true of COVID. COVID has a massive knock-on effect. It has a knock-on effect on those living with HIV. It has a knock-on effect on those living with TB. It has a knock-on effect on those living with both. And we need to ensure that the response strategy to COVID isn't just narrowly looking at the numbers of people who die who are diagnosed with COVID-19 as a kind of measure of the variable you're seeking to minimize, but measures the entire impact, the knock-on impact on other diseases. Because ultimately, what really counts here is that we save the lives of people, that we make communities healthier. Saving people from one disease only from them to die of another is not an achievement. I think another lesson, and here I'm focusing on the lessons that we can learn from TB and HIV to inform the COVID response. Another lesson we can learn from the TB and HIV arena is the importance of inequities, of human rights or gender-related barriers, of stigma and discrimination in impeding the efficacy of approaches to control the diseases. We know all too well it isn't enough just to have the biopharmaceutical tools, the clinical practices. You have to address the underlying determinants, be they legal discrimination, those or social poverty. And the same is becoming increasingly evident with COVID-19. It doesn't have an equitable impact across different groups in society. Not everybody has the same, as we know all too well, access to the tools to prevent it. And what we know so well from HIV and TB is that these problems don't solve themselves automatically. You need action, you need policy action to actually address and attack these barriers. And we will need the same with COVID-19. Otherwise, we will end up with a disease that might be eliminated in many parts of the world, but still causes havoc and death in many other parts. The other thing, and I noticed one comment here that I think we learned from TB and HIV is that one size doesn't fit all, that you need differentiated service propositions if you're going to be effective in accessing and reaching out to and providing either preventative or curative treatment to people. And I think the same will increasingly be seen to be true with COVID-19, that while blanket approaches may work for large swathes of the population, increasingly we will find we will need more tailored propositions to be effective for different groups within society. What about the other way? What are the lessons we can learn from COVID-19 for the TB and HIV response? Well, one thing I think we can learn is that having rapid data, a quick data feedback loop, as I would say, is incredibly powerful, and that we need to do a better job in the TB HIV world of getting good data really fast, so that we can target responses, but also so that we can focus political and public attention on the scale and nature of the problem. We all know that there has been a significant impact in many countries on both TB and HIV, and TB and HIV together, from the COVID-19 pandemic. But it would be much more powerful if we could actually put numbers to that in the same way that we can with the underlying COVID-19 pandemic. A second lesson I take from the COVID-19 pandemic is actually that more things are possible with science than we might assume, and that we should be more demanding of science as to the solutions we need and the speed with which we need them. Because if we can get vaccines and diagnostics, point-of-care diagnostics very quickly, RDTs and so on for COVID-19 so quickly, why can't we get them more quickly for diseases like TB and HIV? And related to this is this point about speed. One of the things that I think we've learned with COVID-19 is the importance of speed. And I think we are sometimes a bit too accepting of the time it takes to roll out new innovations, of the time it takes to change treatment regimens, to implement new approaches to dealing with things in the TB and HIV world. And I think we should learn that time equals lives in these sort of circumstances, and that one lesson we can learn from the COVID-19 response is the imperative of speed. When we have better approaches, we should roll them out as quickly as we can, and thus maximize the lives saved. So I think we face a significant challenge right now on funding TB and HIV. The Global Fund's funding will have increased by over 20% with the new cycle of grants, which is great, but we absolutely understand that we're only part of the story, and that for TB in particular, so much of the funding comes from domestic resources, and there is huge pressure to divert that to the COVID-19 response. We're also, through the C19RM, the COVID-19 response mechanism, which has been very generously supported by, above all, the United States, we're helping countries work out how best to mitigate the impact of the pandemic on TB, HIV programs. But ultimately, we know that until we get on top of COVID-19, and that we will not really get back on track with TB and HIV. And so I think collectively, we face a very significant, not just funding, but execution and political challenge around ensuring that the response to COVID-19 includes the poorest and most vulnerable, including those who are marginalized, stigmatized, and discriminated against, and that the measure of success is not, as I say, just those minimizing those dying with a positive diagnosis of COVID-19, but also ensuring that those vulnerable to, affected by TB and HIV are getting the care and services they required, so that we minimize that knock-on impact. I'll stop there. Thank you, Teresa.
Thank you very much, Peter. A really very impressive and deep dive into the problem and comprehensive strategic view. And really, truly, we should not looking for some unique single solution with these complex diseases, and our response should be really comprehensive. And with these close interlinkages, especially between communicable diseases, we should clearly understand and agree that addressing just only one single disease, you will not be able to reach the target even for one disease. For example, if a number of people, so-called missing people, will remain, the reservoirs will be growing, transmissions will be growing, and it will affect also the most vulnerable people with HIV. So understanding these linkages, of course, we will continue working closely and discussing. And thank you very much for your close engagement and partnership during discussion of the new strategy, Global Fund strategy. I believe that we will find the best possible solution. Thank you for your partnership. So, and now I would like to turn to Anjali Achrikar, acting U.S. Global AIDS Coordinator and Special Representative for Global Health Diplomacy at the United States President's Emergency Plan for AIDS Relief. Acknowledging the support PEPFAR provides for the HIV and TB HIV, I would like to focus and to ask you to focus on the lessons you would like to share learned from PEPFAR experience in assuming gender equality, both for women, girls, and men, and how this can inform our goals for decreasing HIV-associated TB and to move towards our targets of ending epidemics. Please, Anjali.
Great, thank you very much. Really appreciate that introduction, Dr. Kaseva, and really enjoyed listening to the previous speakers before, Marinda and Carrie and Peter and the others. I think it's a really important time for us to come together as we go into this week and look into the future. Again, 40 years since the first cases of AIDS were identified, but really a time now for us to reflect, recommit, re-energize, and re-engage. And this particular session on stepping up the momentum as it relates to TB and HIV, I think is of utmost importance. I think, Peter, to your last point about, or to one of the points that you raised related to the importance of political will in all of this, you know, that's critical. And you know, just to re-emphasize that the United States is unequivocally committed to ending the HIV epidemic, focusing in on HIV-associated TB among PLHIV, through PEPFAR, through the work we're doing with the Global Fund. Very energized to the point that Carrie raised related to the American Rescue Plan and the Biden-Harris's focus on additional resources coming in to address COVID, as well as mitigate the impacts of COVID on the work that we're doing together. We're also very committed to continuous learning from data, constantly improving the implementation in the pursuit of having the greatest impact on the people we're serving. And so, Teresa, to your question about, you know, what are we learning about gender equality and from our other programming and how it could provide some lessons as we're thinking about where we are now with TB and HIV. You know, we've learned a great deal from the work that we're doing together with many of you and across the globe on our DREAMS program, which is our determined, resilient, empowered, AIDS-free, mentored, and safe program that's a public-private partnership that we launched in 2014. I think one of the things that's really critical that we've learned about or from our DREAMS program is much of what we've heard in the previous comments before. It's all about ensuring a people-centered approach. That is critical. DREAMS has really taught us to put people, and in the case of DREAMS, adolescent girls and young women, at the center of the programming, not just at the end, but at the beginning, in the design phase, designing the program, in the implementation, in the monitoring of the program as we move forward. We developed DREAMS with and for adolescent girls and young women. And so when data showed that they were up to 14 times more likely to be infected with HIV than their male counterparts, we put them at the center, listening to them, hearing from them, learning from them in terms of what would make a difference to have an impact on their lives. And so, the program then reflects responding to their needs, the barriers that they're confronted with, and really addressing the specific issues that they have. And I liked the comment that I saw in the chat related to differentiated service delivery. That's also part of the equation and what we're learning from DREAMS, and that also applies to how we need to be thinking about TB and HIV. What works for a 10 to 14-year-old young adolescent girl is not the same as what's relevant for a 20 to 24-year-old young woman, for example. So again, people-centered programming is absolutely critical, and differentiating those services based on the specific needs is fundamental. I think second is the holistic approach that we've taken with DREAMS. Through DREAMS, together with our partners that are on the call here, with Global Fund, with UNAIDS, with Usaid, with CDC and others, we're delivering a comprehensive multi-sectoral package of interventions addressing behavioral, structural, and biomedical factors that drive HIV acquisition for adolescent girls and young women. This comprehensive approach has proven to be quite effective. And again, so as we think about where we are now and where we need to go for TB, and again, it's focusing in on a people-centered approach. Many of the comments that were shared previous to me, a people-centered approach and comprehensive programming. Men are actually at greater risk of TB and HIV-associated TB and mortality than women. So again, understanding those needs of the men, differentiating our service delivery to meet their needs is critical. The point also about socioeconomic determinants of health and addressing those. We must go upstream to address the drivers of TB transmission, the social and structural drivers, the inequalities that drive what we've learned in DREAMS that drive HIV among adolescent girls and young women are often the same as those that shape TB transmission and include economic insecurity, access to education, stigma and discrimination, and some of the other issues that my colleagues have shared. So again, ultimately, investing in the people at greatest risk, implementing comprehensive multi-sectoral integrated programming to decrease HIV-associated TB. It's incredible what's possible when we all come together. Several colleagues have noted the progress that we've made since the high-level meeting on TB in 2019. For example, providing TB preventive treatment to at least, when we set the goal together of providing TB preventive treatment to 6 million people with HIV. And our most recent data that we're seeing, exceeding the target with over 5.4 million people living with HIV, having been treated with TPT since 2019. So again, still work to be done, but what might be possible when we come together. And our work is really not finished, particularly with COVID and the impact that that's had on our programs across the board. We must redouble, triple our efforts, as someone said earlier. Really coming together as a global community to end the HIV epidemic everywhere, but including particularly HIV-associated TB among people living with HIV. So I'll stop there. Thanks, Teresa.
So thank you very much, Anjali. So great to hear from you these important messages on the people-centered, patient-centered approach with a differentiated approach, and especially this multi-sector call for the multi-sectoral actions and engagement. These two diseases, TB, HIV, and of course, not only clearly so heavily dependent on social economic determinants and drivers, and that definitely cannot be ending without addressing these determinants. And earlier we will come to this understanding, especially in the countries, we'll start investing in addressing these determinants better and faster. We will move towards our targets. As we can see from our global TB report, that for example, the role of undernutrition and poverty is dramatically growing, and we can expect an even further growth, even when we will overcome the epidemic, hopefully soon, with this socio-economic impact. So that's why I can't agree more, and this is essential, multi-sectoral engagement and cooperation. Thank you very much. Now with pleasure, with a special pleasure, I would like to give floor to Dr. Lucic, Executive Director of the Stop TB Partnership. I know how many sleepless nights she's spending brainstorming, thinking, working, and trying to identify the key actions, measures, how to provide better response, address essential TB needs. Lucic, I would like to ask you, what are the key asks from the TB community we can bring during this high-level meeting on HIV/AIDS, in particular for addressing equitable access to TB/HIV services for all? Please, Lucic, the floor is yours.
Thank you so much, Teresa. And I want to thank, first of all of you, WHO, and the entire amazing lineup that we have right here you know, right before this important event of the year, the UN high-level meeting on HIV/AIDS. So I really want to thank you very much for bringing us all together in such an important conversation. We are in June 2021, and very nicely, Shannon Hayder said that we, and we all said, we will have 40 years of HIV. We just kind of reminded all of us of the 40 years of HIV/AIDS existence. There are hundreds of years of TB existence, and in spite of that, just let it sink in there, that in spite of knowing this disease for hundreds of years, and as you already heard, knowing how to diagnose this for more than 100 years, we have TB still killing 1 in 3 people living with HIV/AIDS in the year of 2021. With all the progress, all the work, and all the scale up, HIV/AIDS is becoming a chronic part of life of people. It is completely unfair that these people living with HIV/AIDS and going through so many challenges to die because of tuberculosis. It is absolutely difficult to understand that. And now what I'm afraid is we will observe with COVID that actually as TB is there for hundreds of years, for thousands of years, TB as a disease, we saw coming and going a lot of other epidemics and pandemics, but TB remained there, growing, never disappearing. I'm afraid that now HIV is joining with TB. In being there, we will have epidemics coming and going. People will get mobilized to end them, as we observe now with COVID. But both TB and COVID, TB and HIV will remain. And if anything, after this COVID, for example, I am pretty sure what we will see is an increase. So one of the first things that I want everyone to really absorb is that for once in life, places in which the TB and HIV co-infections are very high, we know that in African countries, it can go to as high as 70%, as high as anything above, I would say, 30%. I really make a plea to the political leaders of these countries to put in their head that what kills the people living with HIV in these countries is tuberculosis. And I invite them to really speak about TB as eloquent and as educated as they do about TB, about HIV, because it is not happening right now. And we've seen into some speeches today a little bit of that. So it is extremely important that the language, it is extremely important that the political commitment for TB in places in which TB is such a big killer of populations, it's such a big killer of people living with HIV/AIDS, it's there, it's in the heads and in the minds of governments and key stakeholders for TB, for HIV, for the health of their people. Peter Sands spoke about the data. We see now on the corner of television in most nations daily data about COVID. If that same television will put a corner about TB and HIV in some places and so on, we will observe that the minds of people and the understanding will be changed. Only that we are not used to work with live data. We are not having them. And that's why we from Stop TB and everyone I know here in this meeting, we add to our voice to really do our best to get this data and to have this live data that we can make the case. Teresa, for investments and continued attention to TB, to HIV, to TB, HIV. Teresa, you asked about what the TB community would like to see. And I know that everyone here spoke about more or less the same targets, but I just want to make sure that we need to reduce the TB deaths among people living with HIV by 80%. By 2025, we need to ensure that at least 90% of people living with HIV who are eligible for TB preventive treatment receive and complete treatment. We need to make sure that this was not really presented that much, but it's something very important for us, that we mobilize, equip, and maintain joint infection control systems to prevent the spread of airborne infectious diseases in such a way that we prevent as well people living with HIV from developing TB, COVID, or any other respiratory infection. I just want to remind all of us that if we have any future airborne pandemic, TB will be there. What goes through the nose ends up in the lungs, and that's why the diagnosis, the infection control, the contact tracing, and everything will be constructed, all supported by the systems developed for TB. We need to strengthen the TB services for adults and children living with HIV and ensure that all people living with HIV who are on antiretroviral treatment have access to adequate TB diagnosis, treatment, including drug-resistant TB, prevention and care, so that 90% of people living with HIV who are affected by TB are receiving treatment for both conditions by 2022. And I think that both Kerry and Anjali mentioned about this target. It is very, very important, and this is something that is the core, close to our heart in Stop TB. It's something that everyone mentioned, is that we ensure that the TB and HIV services are equitable, are person-centered, rights-based, are accessible, take action to eliminate stigma and discrimination that we know is experienced today by people living with HIV, by people living with TB, or the people that have both. And I want to say that COVID, not only that rolled back our achievements in terms of numbers and everything, rolled back the ground that we gained in rights, the ground that we gained in gender sensitive programs, the ground that we gained on destigmatization. It brought us back. That the inequalities that COVID showed and keep showing in the world, within the countries, in the same country, even in the same city between different populations, is absolutely unacceptable and mind-blowing. So Anjali, right before you spoke very clearly about putting people at the center from the beginning. And it's not embraced everywhere, and it's not embraced by everybody. So I think we in TB community, in the HIV community, we really need to come together in addressing this piece, because only that we will change these approaches in which some people decide for others how their lives and how their health can be provided. We need to, another ask is to really increase the financing for research and development of new tools for TB prevention, diagnosis, and care among people living with HIV populations, as well as in the context of COVID-19, addressing screening, testing, tracing, diagnostics, infection control, as well as the drivers of diseases that were mentioned, as well as support the people with related costs, such as the transportation, mental health support, and legal aid. These are some of the things that are often forgotten, but for each individual, this means the world. And it's extremely important that we start looking at these numbers, that stop looking at these numbers that we have and start looking at the individuals and their needs. And there are all these packages around them, as we heard here, are extremely important to be in place. I really hope, we had the UN high-level meeting in 2018, and we are planning to have a UN high-level meeting on TB in 2023. That will be a great momentum, because it will be a halfway from this HIV meeting that starts tomorrow. So it will be good to take a pulse of what is happening 2 years along the line. My last point that I want to make is related to the fact that it starts with willing. It starts with us wanting to end something. It is in our power to end these diseases by 2030. With all the COVID impact, it is still possible. It is important if we want. If there is a will, there is a way. I never doubted that, and I know that none of you doubt that. We are here, an amazing group of people. Our lives are devoted to fight these diseases. Our achievements or failures will remain forever in our lives, but will impact the lives of other people. We have a responsibility and we are accountable to really serve the people that without a voice and without a power are putting their hopes on us. I call on all of us, as well as the participants to the UNHLM meeting on HIV/AIDS, to really put all the efforts to end both TB and HIV by 2030. Thank you.
Thank you very much, Lucica. I wish you and the all TB community, all of us, that your kiosks, your words would be heard by the decision makers and will be implemented as soon as possible. We should agree with you. We should be driven not only by threats, but by the real needs of the most vulnerable, the poorest people. So I would like to give a floor to our next panelist, Hank Tomlinson, Director of the Division of the Global HIV and TB at the US CDC. Given that COVID is has a risk to take us years back in our joint response to TB and HIV, what do you think we should do the best to build back stronger to address the response to TB, HIV, and what lessons learned and innovations can be leveraged from the COVID pandemic? Please, Hank.
Thank you, Teresa. Also, thank you to all of the speakers as part of this roundtable for stakeholders, but also who spoke prior to me. I think that you will have heard by the time that I finish convergence around a handful of key issues. I think that we are aligned in the way that we see the way forward. And Teresa, I'll note that you've added kind of there are two parts to the question. The first is, given that we've been set back in global TB and global HIV activities, what can we do to get back up to speed and accelerate? But then also, what can we learn from COVID-19? So CDC has worked in partnership with host country governments and national governments on the front lines in 25 countries to address global TB. It's my pleasure to be here today with our other colleagues from the United States government, from USAID, and the President's Emergency Plan for AIDS Relief to represent the substantial investments and activities that we're making in HIV, HIV-associated TB, and TB itself. And in those 25 countries, those high-burden countries where we've worked on HIV, we've also been working hand in glove with host country governments on COVID-19 responses and representing the interest of the entire US government and other stakeholders. So although COVID-19 has pushed us back several years in the global TB response and maybe a little less so in the global HIV response, it's also illuminated opportunities and provided us a chance to see how to quickly and successfully overcome or deal with some challenges. I'd say in response to your questions, there may be like 3 high-level issues that I'd want to highlight and then maybe get into specifics after that. And so some cross-cutting concerns, I would say, first is that strong systems and strong networks are critical to addressing both ongoing TB and HIV and emerging COVID-19 public health threats. So COVID-19 highlighted the importance of strong health and public health infrastructures and networks and how they can be used to effectively address ongoing and emergent public health threats. TB program staff, TB clinicians, equipment, and community programs were among the first, along with HIV programs and program staff, to pivot to COVID-19 after identification of the virus and our sort of collective development of an understanding of how significant this was going to be. Diagnostic and programmatic infrastructure and capacity built through those HIV and TB programs were also capitalized on at every twist and turn along the way in the COVID-19 response, and will be for years to come. So we can use what we've developed in global HIV and in global TB for purposeful benefit for COVID-19 and beyond. So I don't want to lose sight of the fact that our investments in diagnostic activities, surveillance, laboratory more broadly, like those all have collateral and purposeful benefits for emerging threats. The response to the COVID-19 pandemic also enabled broad and bold coalitions of partners in public health, in pharma, the tech sector, and civil society that can be instructive on how to fight TB, including around vaccine and therapeutic discovery, community coalitions for information, education and patient reform, education and patient support, and digital screening and contact tracing technologies and platforms. If we can tap into these coalitions to address the TB-HIV combined response, we could erase some of those lost gains quickly. The second point to make that's sort of cross-cutting, and this is a recapitulation to some degree of what you've heard from Peter and Anjali and others, is that accurate, timely, and granular data are key to accelerating impact. This is absolutely essential. You heard Lucic talk about the counters that we have on television screens for COVID cases and what it would be like if we had that sort of, awareness in a popular way about TB, HIV, or TB-associated HIV. We've seen time and time again countries across the globe have demonstrated their ability to report on real-time data and to use epidemiology of the pandemic for COVID-19 to understand the scope and the pace and necessity of interventions. And the availability and use of this real-time data have been instrumental in guiding the COVID-19 response. That's something that we can purposefully learn from, and we should take in all of our sort of work moving forward. PEPFAR and the global HIV response has already been a leader in the collection and the use of facility level data for program planning and improvement, and our continued need to innovate around data systems and real-time reporting can drive real-time quality improvement. The third, and again, I'm totally aligned with Peter here, and that is the speed with which we act and the expectations that we think are acceptable. So that's speed of science, it's speed of program implementation, it's speed of critical review and analysis of what we're doing, and speed of our feedback cycle, our continuous quality improvement efforts. That requires political will, but political will is not sufficient. We have to raise expectations. This dovetails with what you heard from Lucic as well. Raising expectations for both achievements, an acceptable rate of change, and disseminating and making use of innovations, and stopping those things that don't work. We've got to act more quickly and not accept the pace of change that's been what we've experienced in TB for a long time. Finally, with regard to specifics, kind of what we can do to make up for lost ground and what we can do to learn from COVID-19, that's really the adoption of innovative approaches such as people-centered and community-focused differentiated service delivery. So again, I'm not telling you something that you haven't heard from other speakers, but this is what we believe is essential. So differentiated models of service delivery and integrated approaches to disease management will be essential to overcoming our TB challenges. And so the first is, as you've heard from so many others before me, people-centered and community-centered or community-focused differentiated service delivery models. And so in HIV, we've talked for years about differentiated models of service delivery, meaning you think about the what, the who, the where, and the when, and you design a series of services that are responsible or responsive to people and clients' needs for testing, prevention, and treatment. We've seen that and done that for TB HIV with the rollout of TPT in our PEPFAR programs and in our CDC programs. I think we can go beyond HIV-associated TB and do that more broadly for TB, and that will benefit TB HIV, but TB, core TB as well. Adoption of those differentiated service delivery models and moving them to the center also recognizes the centrality of communities and of people in the response, and we won't succeed if that's not done. Adopting integrated approaches is the next thing. And I think that you've heard this again from a number of speakers, but during and after we face challenges posed by COVID-19, it'll be important to continue to find ways to explore how to integrate responses across diseases, programs, and disciplines to mitigate the impact of emerging threats and to bring to bear the existing resources that we have for the COVID pandemic and beyond, and to also catch up and accelerate progress in global HIV and TB. This happens through integrated disease screening for respiratory and other diseases, so TB, COVID, and HIV in the mix, and using integrated laboratory platforms. We've got Expert, which is remarkable for COVID-19, for TB, for HIV testing. It happens for integration of infection prevention and control for healthcare workers and in facilities for patient safety and protection, and contact tracing, something that TB programs have been doing for a long time, or should have been doing for a long time. We know in many high burden countries that hasn't received the attention and effort that that we'd hoped and that they'd hoped, and this is a renewed sort of push to do that in the face of how important it's been as a strategy to contain or to mitigate COVID-19. I think that the last things I'll say, Shannon's opening comments about intersecting inequalities, stigma, and discrimination are part of our sort of vision for having communities at the center and for people-centered programming. And the catastrophic consequences, economic, social, and otherwise, for TB infection, for HIV infection, if we don't deal with those, our efforts and strategies are likely to be met with limited success. And finally, I want to also just acknowledge that as much as COVID might have set us behind a little while, we had some gaps in TB HIV service delivery before COVID, and it is time to double down on those. And so quality of TB screening and the yield of TB screening, it continues to be suboptimal. We need better screening modalities paired with more consistent quality implementation of screening at every encounter, and there are new technologies and approaches that can improve yield and efficiency. Despite the availability of novel diagnostics like Experts, LAM, the incorporation and consistent use of those tools and diagnostic algorithms remains suboptimal. And so we need to harness available novel techniques for diagnosis, for treatment, for prevention, including using alternative specimens like urine and stool for TB diagnosis, and implementing shorter regimens for drug-susceptible TB and TPT. Finally, I would say, we still have a gap, even with the remarkable progress that we've made in the scale up of TB preventive treatment among people living with HIV. We have a gap to close. There are more people that start than finish those TPT regimens, and we want to make sure that we've got as close to 100% completion rate as possible. And as Shannon and others have mentioned, working with children and household contacts, not just people living with HIV who are reached in the program rollout of, through the HIV program of TPT, but going beyond that. We have so many tools at our disposal. If we want to do this, we can. I feel like I'm echoing Lucic here. It's, in my mind, about using those tools for optimum benefit, about raising expectations, and about working faster. We at CDC, we in the US government stand committed to helping our partners and host country governments around the world do exactly that. Thank you for your time today.
So thank you very much, Heng. It was great, and again, very comprehensive. It's wonderful, amazing to see how unanimous all our panelists are in their opinion, in agreement, and reaffirming their strong commitments. Yes, we are now all learning from this exercise. Our weaknesses become more obvious. Our advantages we can see also as well, and one of the advantages, these investments into the HIV and TB programs brings also benefits. We can see how heavily we are involved also into the COVID response, how our capacity of our community health workers are now contributing to the COVID response, knowledge about infection control, contact tracing, and all other essential knowledge of the communicable diseases. We definitely should continue investing, and we should not use this situation as as an excuse not to move forward and not to protect people and achieve our targets. So we have a very rich discussion, but I would like to let you know once again that we have more than 200 participants joining us with huge interest to the topic, and it will not be fair if we will not give them opportunity to ask few questions. And with this, I would like to give floor to my colleague, Dr. Farai Mafunga, Unit Head for TB Vulnerable Populations, Communities and Comorbidities, to lead a brief Q&A session. Farai.
Okay, thank you, Teresa, and thank you to all the panelists. I would also want to thank everybody who's contributed in the chat. I think there were quite some interesting comments that have been posted in the chat. In the interest of time, we will only be able, unfortunately, to take one or two questions. So we'll start. The first question from Sanjita. She is asking, what innovations and digital technologies can be harnessed to tackle TB HIV response, especially in the COVID-19 era? So maybe we can start with Kerry, if you have any comments or any perspectives related to that question. Over to you, Kerry.
Thank you so much. It really has been remarkable how much we've come together during the panel, and I think we will on this priority focus on innovation as well. I really appreciated Hank's point that political will is necessary but not sufficient. And we know that along with political will, we need really innovative approaches, and they will be critical. We in Usaid and the Bureau for Global Health have a Center for Innovation and Impact, and that conveys to you just how much of a priority we put on innovation. For TB and TB HIV, we know innovation is required along the entire spectrum, from testing, diagnosis, treatment, and adherence. All of those require innovations. Two priorities we are focusing on in the program right now include bidirectional testing and integrated contact investigations to use AI technologies for chest X-ray diagnostics, integrating TB, HIV in integrated service delivery modules under PEPFAR, and that point about integrated services has come through loud and clear today, and also multi-month scripting to include TB and TB preventive therapy treatments in addition to ART. I do think the multi-month dispensing has been a tremendous policy breakthrough under PEPFAR programming, and so that's something we also want to follow up on. We're also using telemedicine and remote clinic consultations to minimize clinic visits during the time of COVID, but was mentioned also by other panelists, we need to draw on lessons that we've learned as a result of COVID and apply them to the program going forward. So I just wanted to touch on those few. I'm sure my other colleagues have additional points to cover on this important question. Thank you.
Thank you so much, Kerry, for those comments. Anjali, maybe you would also like to share your perspectives on the same question. Over to you.
Sure. Thank you so much, and really appreciate the conversation. And Kerry, just to amplify a couple of things, because I think you really covered the broad swath of what I would have described. I think, you know, we've learned a lot. We've learned a lot coming out of COVID-19 and going through COVID-19 as it relates to what specific services, what differentiated services are critical for clients, patients themselves. And so again, these are very relevant for how we should and can be tackling TB as we think about moving forward together. Kerry mentioned multi-month dispensing. Community service delivery has been really critical. Pickup points within the community closer to the homes where people are is very essential. So again, you know, the telehealth, the telemedicine that Kerry noted, again, these are really important innovations that we've been deploying that are very, very relevant and should be brought to scale for TB as well. So I'll just pause there, but thank you for that good question.
Okay, thank you so much, Anjali. In the interest of time, I unfortunately am forced to hand the floor back to Teresa. But before I do, just to check if any of the panelists would like to comment on that question as well.
Yeah, hi, this is May. I just want to add for the digital technology and innovation for the TB HIV programs, especially during the pandemic. I think this is also time for us to utilize the HIV self-testing, because when we can diagnose people earlier about their HIV status, so this has become very good for us also to prevent TB. And also to ensure the patient on TB adhere to the treatment, and also people living with HIV adhere to their treatment. I think we can also use our new technologies, not really new, especially that because all of us use these applications. We can use our mobile phone to ensure that to check whether they already take their medications, and also we can provide them psychosocial support by mobile phone, and also we can use the website page as a web-based training courses, and also we can use web page for the health information system, not only for TB, HIV, also including COVID-19. Over to you.
Okay, thank you so much, Merinda, for those additional perspectives. So that said, I would like to thank all the panelists who have contributed to this discussion. I know there were others who would have wanted to say more, but in the interest of time, I hand over the floor back to Teresa. Thank you so much.
So thank you very much, Farai, and I would like to thank all our distinguished panelists, speakers, excellencies. It was very, very rich discussion, and it shows that we don't have enough time even to discuss all our topics. And in fact, we should have time, and we should do our best, importantly, to work according to our highlights, key asks, and commitments. So, and once again, thank you very much. Definitely, we will stay in touch, in close collaboration, because collaboration is absolutely essential and critical instrument nowadays to support people and to adequately respond all the threats, new and old threats. I would like now to ask with pleasure Dr. Ren Mingui, Assistant Director General for Universal Health Coverage, Communicable and Non-Communicable Diseases, to share his closing remarks for this important meeting. Please, Dr. Ren, floor is yours.
Thank you very much, Teresa. Your Excellencies, Professor Peng Liyuan, honorable ministers, distinguished delegates, partners, and friends, thank you very much for your participation in this side event on ending TB deaths among the people living with HIV, organized on the sidelines of the United Nations high-level meeting on HIV and AIDS. I hope you have enjoyed this very important, inspiring, and informative speeches and panel discussion, and that you have been able to reflect on the key message raised by our distinguished speakers and the panelists. At United Nations high-level meetings on HIV and TB held in 2016 and 2018 respectively, the head of states and other leaders made bold commitment to accelerate response to TB and HIV. Resultant political declarations both highlight what needs to be done to end this epidemic by 2030, in line with Sustainable Development Goals. This commitment has provided hopes for ending deaths and the sufferings of millions of people worldwide who are struggling with TB or HIV, including many of them affected by both diseases. There is, however, still a long way to go to achieve the goals of ending HIV and TB, and the current COVID-19 pandemic has significantly set us back. On the eve of this United Nations high-level meeting on HIV and AIDS, we have a very important opportunity to deliberate on required actions to overcome this setback, the social economic impact of COVID-19 will have a disproportionate impact on those affected by TB and HIV, and will therefore must redouble our efforts to expand universal health coverage and improve the access to integrated people-centered care in a speeded way, as many speakers and panelists said. As highlighted during the discussions today, they are especially important for those in poverty and for disadvantaged and vulnerable population. Sustained and increased political commitment and a focus on TB and HIV epidemics, alongside other emerging and growing health challenges, is required to reach our goals of ending TB and HIV by 2030. We also need to remove structural, social, and economic barriers to good health, and in this regard, I recognize and acknowledge, appreciate the contribution by our representative of affected community, Marida, during discussion today. We also learned from COVID-19, this is possible to rapidly scale up screening and testing capacity, and it should give us renewed optimism that the universal and early access to the TB screening, diagnosis, and treatment with latest available technology can indeed be achieved. This will be critical in our efforts to regain the ground that we have lost to COVID-19, but we also need to be complemented by social protection and concrete actions to address the vulnerabilities and inequalities. Given that we have only 18 months away from 2022 targets set at the last United Nations high-level meeting on TB, this is vital. This is vital that we all unite to implement the priority action outlined in the 2020 UN Secretary General Progress Report on ending TB. The challenges is to all sectors and stakeholders, including the governments, ministries, partners, the private sectors, healthcare workers, communities, and those affected by both diseases, to implement recommendations in this very important report. Your Excellencies, honorable ministers, distinguished delegates, partners, and friends, I once again would like to thank our eminent speakers and panelists for making time to participate in this event today. Finally, thank you to our wonderful audience for joining us from different time zones as we keep our spotlights on ending TB deaths among the people living with HIV. We need to step up momentum to end TB deaths in the people living with HIV. The time is to do that is now. The clock is ticking. Thank you for your attention. Now the event is closed.